Good afternoon, ladies and gentlemen. All protocols observed. Yeah, so this afternoon we're going to discuss the topic of how we can move towards universal health coverage by strengthening surgical systems. And I would like already to start, Chair, if you allow me, that I may switch between surgical or perioperative healthcare. For the reasons that, like I said, if we really are going to achieve universal health coverage, then we must really take care of the equity part of the progress that we want to make. And equity requires that we attend to those that need whatever we are trying to do the most. And those are mostly the people in the rural areas, especially at the lower levels of care in primary health care, which then brings in the issue that when we talk about surgery or surgical, most of the time people want to think about what we do in the hospitals only. But if you really want to address the surgical patient, then you must also consider what to do for the patient in the community. So the pre-hospital part of it is really important, as the intra-hospital, and of course the post-hospital part of it, which goes back into the community. So for us to really be comprehensive, we must talk perioperative. And in the Republic of Zambia and in SADC, that's the language we are adopting so that we are more comprehensive and also aligned with a lot of other policies that we have. And I'll mention some of them as we go. I obviously chair the SADC Technical Experts Working Group, and I run the Regional Collaboration Center for SADC. And I've got a lot of working relationships with all those entities that you have seen there. So here I'm just declaring my interests and relationships. I have no conflict of interest, except that I'm always interested in trying to ensure that everybody can have the surgical interventions that they need without having to face any catastrophic costs. So in this presentation, I'm mostly going to focus on the how-to. I have framed it more to be some kind of policy advisory. The how-to is basically, how do we translate political commitments, which are in form of resolutions or decisions that we pass at intergovernmental platforms, especially at the UN through the lead agency, the World Health Organization, into service delivery that actually touches the person. How do we do that? And these resolutions and decisions, as you know, they're not only at the UN. We pass resolutions and decisions at the African Union. We pass resolutions and decisions at the EXA, Health Community, East, Central, and Southern Africa. And of course, a lot of other platforms, including WHO Regional Committee through AFRO. So it's very easy to pass resolutions. Of course, there are challenges about how you negotiate resolutions, but how do we really translate this is always the missing piece. And that's actually what we need to know. How to do it, how to convince others, how to ensure that we can ensure the patient receives the care that they need. Now, there are many resolutions. Here, I've only used the World Health Organization resolutions. Like I said, there are others that we've already passed on this topic in EXA, in SADC, at AFRO. And the resolutions are many. Like I've said, I've listed a few there. Of course, the Global Action Plan for the ECHO resolution is missing. It's a decision that was passed last year in 2024. So if you were to look at any of those resolutions, you will see that there are components that touch on issues of surgical care or perioperative health care. The one I've highlighted, 6815, is obviously the best known resolution, which was very specific and said strengthening emergency and essential surgical care and anesthesia as a component of universal health coverage. So through that resolution, all the 194 member states endorsed and recognized that surgical care or perioperative care is part of universal health coverage. And without improving that, there can never be a universal health coverage. Now, in the high level decision that also was on universal health coverage in 2019, the surgery that is mentioned, obviously you just see one little word in paragraph 2035. But this, again, was just to highlight that even in the high level decision at the UN in New York, issues of surgery still remain very critical in the acceleration. Now, this meeting was called to try and see if the countries or governments could mobilize their support to try and do more. Because as you know, we are inching closer to 2030. It's 5 years away. This is 2025. So it's not too far away. And if you ask yourself, how much have we done? Have we really made any progress towards the goals that we set for ourselves in 2015? I would like to hear from you. What do you think? Anyone? Personally, I think that we haven't moved much. We're really, really very far. 5 years is basically just one plan for a government. Governments usually make plans in 5-year, periods. And so we're remaining with one chance to do something more to ensure that we can accelerate. In fact, that's why you see me talking about accelerate. It's not walking or moving towards UHC. We must try to run faster towards the finish line because we're remaining with very, very little time. Now, let's do some definitions so we understand what we're doing. Universal health coverage means, every good health and well-being. In other words, it said good health and well-being for everyone. But if you break it down by the definition, it talks about 3 issues. It talks about equity in access. Equity, not equality. There's a difference between the two. Equity means those who need more, you give them more to bring them to speed. Equality means you give everybody the same thing. And in the delivery of surgical health care or perioperative care, we must use the aspect of equity. There is no equity in the delivery of surgical services. Like I said, the lower levels of care are not getting any service. The poor, the people in rural areas are not getting any service. So even in our process, in our progress to try and get universal health coverage, if we're going to do it equitably, we must prioritize those people. And that's why in my presentation today, I'm not going to be talking about what happens at Mulago Hospital Chair. I'm going to talk more about what happens or should happen at the district hospital and the rural areas. Now, goal 3, and UHC is actually target 3.8 of goal 3 of the SDGs. So it's part of the SDGs. Now, goal 3 itself is foundational because none of the other SDG goals can be attained without good health and well-being. So it's really foundational. If we cannot achieve anything in goal 3, I don't know if we can achieve anything anywhere. For us, obviously, in SADC, even if we get to 2030, we will continue to work on this. Even if the world decides to change, obviously they're going to meet up and come up with some other things that they're going to set for themselves as a world body for development. But for us, development is not going to come without good health and well-being, and we will continue to work on this, even if the nomenclature or the targets change. Now, if you relate what universal health coverage says and the situation that was painted as far back as 2015, you obviously can see that we cannot really achieve universal health coverage without that. 5 billion people lacking access to safe surgical health care. How can you say the world can reach UHC or Africa can reach? And most of those people actually are in sub-Saharan Africa or below the Sahara Desert, which is us in our region. So there's never going to be any universal health coverage for us with such statistics. And I doubt that the numbers have changed much because we are still in the process of formulating our national surgical plans or policies and developing the programs. So business has continued as usual while we are trying to set up the roadmap and skeleton frameworks that can help us to start closing the gaps. The backlog of people who need surgery is very big. The additional surgeries that are needed is huge. In our systems, when you go there, you find that the waiting lists are very, very long. And it's not only waiting lists for actual surgery, even just for outpatient care. The waiting lists are very long. If you come to my hospital in Lusaka, the University Teaching Hospital, you may get an appointment to see an orthopedic surgeon, which is after 6 months. So the waiting lists are long. The need is big. Okay? And we also got evidence that investing in surgery is cost effective. The World Bank, through the DCP3 essential surgery, volume publication, clearly made the economic case. So it's not true for anybody to say that it's expensive to invest in surgery. It's not worthy. We don't need it. Only those that are rich can have surgery. Okay, and we all know through medical education, and I'm preaching to the choir here, everybody is somehow related to health. even if we have journalists and media personalities here, I know that they understand. They know that surgery is a huge, it's a component of health systems. Even in medical education, you go through surgery as a rotation. It's a foundational part of your training. But in practice, how come it's only delivered in certain points, in certain pockets around the country, and the rest of the facilities cannot deliver surgical care? Surgery is an indivisible component of our health system, but we have not fully developed it. And obviously, there could be a lot of other reasons. One of them is basically understanding the whole surgical health system and how it operates. This slide, again, like I said, in this presentation, I'm using a lot of material that has been developed by a lot of other people. This came from the Lancet Commission. Here, I'm just trying to illustrate how access to care doesn't really exist in our systems. So if I put at the beginning there, I say country A, I can put my country, or I can put Uganda there. The first part about the timeliness of surgical care, which obviously has a lot of determinants are more outside the health system. They are in the other system. That's why, again, developing a surgical system is kind of complex, because you have to work with stakeholders and parts of our society that are outside the health sector. That is to do with a lot of the patient decisions, transportation things, and stuff like that. But if surgery is not delivered timely, then there's no access. As you can see, it's self-explanatory, and you can keep going up to the top. Okay? There is the issue of the capacity. Sometimes a patient can come to a facility, but the district doesn't have the capacity to provide surgical care. So obviously there's no surgery, even if there's a hospital. Okay? The hospital may have, maybe the capacity may be available, but the surgical service is not safe. As you know, most of our surgical operations, especially in the lower levels of care, is not provided by experts, trained experts. We're not saying that the surgery provided by non-experts is bad, but that's why they're non-experts. We cannot totally trust everything they do. They need a lot of supervision. They need a lot of capacitating. And there is also what they can do. Our clinical officer colleagues cannot do everything that you can do as an expert. And so we also know that there is information in our countries that most of the surgery that is being performed is not safe, because the demand is so high and the people to deliver the care is so little, such that people do whatever they can do, sometimes for the money, because it costs a lot of money, by the way, to receive surgical care. Most people have to pay a lot to just receive the care, and it's not even safe. If the surgery being provided is not safe, obviously, there's no surgery. And like I said, sometimes it's also, the cost is very high. So all those things in this infogram is very applicable to our situation when we apply to access. So it's not good enough just to have a hospital. Or you can have everything else, but if your patients cannot get to the facility, it's not your fault as a health system, of course. But if they can't get to the facility, there will be no access. So the access issue, obviously, this infogram explains it very well of what we face. Now, we had studies that were done in our continent through a snapshot by the South African team, the ASOS group, and you can see what they have shown there. 1.2 billion of the 5 billion people live in our continent, and 95% of these do not have access to safe surgical health care. That's big. So you can see, out of the people lacking access to surgery, the whole red piece belongs to us, sub-Saharan Africa. So we are affected the most. Again here, on the issue of safety, ASOS also found that out of our patients, you know that when you look at the patient of Africa or sub-Saharan Africa, the young people are the majority. Okay? They probably make up more than 50 or 51% of our population. So our young people, normally they should be quite healthy. Young people are always much healthier and they recover much better. But when we do surgery, we lose our people much more, even in the perioperative time, more than people in the Western world, where we have people in their 70s. Look at the population of Europe or the US. It's full of old people who we expect to have more complications from surgery. But we are seeing more complications in our people than they are seeing in the old people. Obviously, there's something wrong. We are failing to rescue. Our monitoring and everything, even where we are providing surgery, it's not really safe. Again, like I said, this was just a snapshot. You can imagine if this was more detailed. Now, for all these reasons, that's why surgery was prioritized by governments, by you yourselves, the people working in the surgical space. For governments and for everybody, obviously, health is wealth. Most of us don't know that. So in our life, we prioritize houses, motor cars, and things like that. Rarely do we really think about our own health. Most of us don't even have our health insurance, but we have a Mercedes-Benz. I'm not lying, am I? Yes, we don't look at health as anything, important, but health is wealth. If you're not healthy, nothing else matters in your life. You can go ask the people who are almost dying. If there was anything that they would pay for, they would want back, it's their health. They can give up anything that they have for health. It's true. So we must start thinking and prioritizing individually. It starts with us as individuals. We must start prioritizing health because it's the first, when we're talking about wealth, it's the first thing that we really must invest in. Okay? I've already made the point that with the statistics that we have just shown here, there is no way we are going to attain universal health coverage if we don't address the surgical needs of those 5 billion people who lack access. Or is it 95% of the 1.2 billion that live in our continent? Now, the whole process somehow has been challenging also because when we start looking at the surgical systems or improving the surgical system, it is cross-cutting. It does not sit in one place. It's very difficult. Most of the time, our health systems have been developed with vertical programs, TB program, malaria program, HIV program. They run from the Ministry of Health to the facility. Sometimes they just need the physician, a lab result, and they can solve it. But for you, as a surgeon or people working in the surgical space, me alone, I can't do surgery. I need the anesthetist, the perioperative nurse, the porter. It's a team. It's not possible. I can treat malaria alone, but I cannot operate on a patient alone. Okay, there is surgery in every aspect. Like I said, in primary healthcare, there is surgery at all levels of the system, even in the community. So it's a vast program or thing that we want to address that is very cross-cutting. So it's complex. And because it has a lot of actors and stakeholders, sometimes it becomes a little bit problematic and difficult to do. But we are determined to ensure that we can solve this because in the SDG era, we really want to work in a horizontal way. If you look at the MDGs, which is the top infogram, those things were very vertical and very, very specific. In the SDG, everything is really connected. Now, but we think that in the complexity of the SDGs and in the complexity of trying to strengthen a health system, so what do you start with? Because the health system in itself is very complex and very detailed. What can you start with? So we propose that starting with surgical systems or surgical care could be a magic bullet that a country could use to accelerate the progress towards universal health coverage. And in this presentation, we'll try and go into a little bit more details. These slides, I'm just showing you the other things that improving surgical care can impact in the SDGs. So it's not only impacting universal health coverage. There are other targets that I've shown here. Forgive my poor eyesight, that's why I'm wearing glasses now. I'm becoming an old man, you can see even from my beard. But there are several targets on NCDs, reducing death from road traffic accidents, and a lot of other targets there that we have on the SDGs. We'll share the slides that will be impacted by improving surgical health care. Even when it's customized to children, again, the SDGs have got certain targets that are very specific to children. The improving surgical health care could also impact them positively. So surgery, like we say, can impact more than just universal health coverage in the SDGs. Now, I'm going to talk a little bit more about why surgery, how does it really help us out? First, I already talked that let's start thinking comprehensively. So we don't only talk about what happens in the health system proper as we know it, meaning we only go up to maybe district hospital, because usually there is very little operative care or cutting that happens in the clinics, maybe incision of abscesses. We must go beyond that. All other programs have even got health promotion, health education programs in the community. Our community doesn't understand or doesn't know what is a surgical condition. And that's why they like to go to papas for prayer for a cancer. It's obviously something that is surgical, but they don't know what it is. Sometimes they think it's witchcraft, or they will think that prayers are going to get rid of it. Our community lacks information about what is a surgical condition. As global surgeons or people working in the surgical space, let's think up to that level. So we have to go beyond what we always traditionally know as health. We must go into primary health care. We must go into health promotion, health education. We must partner with the media because we need to educate our population, and we also need to know the real burden of disease. The Lancet Commission did a good job, but that was mostly made based on models, mathematical models. So it's not accurate. The picture could be bigger. As you know, when you're building a mathematical model, it depends on what input you put in, isn't it? If you have got, how much research comes out of sub-Saharan Africa? Very little. So when they put those things, even WHO information is based on modeling, mathematical models. It's not accurate. So if you're putting in very little accurate information, whatever you're coming out is just dreaming. You're just dreaming. It's not the truth. We must try to understand the true burden of surgical disease, even in the community. And we also must play a role in educating the community to understand and take responsibilities for their own conditions. Because, like I said, one, they don't know what they have is a surgical condition, and sometimes they don't even know where to go. They don't understand our systems. There is a lot of delays within our system. A patient comes with a surgical condition, paracetamol, go back home. Tomorrow, Brufen, go back home. Tomorrow, go to the next facility. By the time the patient gets to you, the cancer is stage 4. Because you were just playing around, you didn't know how to transfer the patient and ensure the patient gets to where they need to care. So the problem is not only up here. The problem goes the way down to the community. We must ensure that we can play a role and ensure that surgery can play its equitable role in improving the health system, starting from the primary health care. Now, surgery, like I say, I've talked a lot about primary health care. These are a few conditions that we've mentioned just to show you the cross-cutting nature of surgical care. It's important in the primary level of care. When you are managing non-communicable diseases like diabetes, cancer, injuries, surgery plays a key role. In maternal health and women's health, surgery is very, very key. If you're dealing with congenital abnormalities that impact young people, in our settings, surgery, we don't only talk about surgical site infections, but we have a lot of infections that are surgical conditions, abscesses, pyomyositis, chronic osteomyelitis. I can keep going on, and septic arthritis. Those are infections. But the treatment or the management includes surgical interventions. Okay? There's a lot of other surgical conditions, and even when we talk about emergency preparedness and response, we use a lot of surgical tools and protocols, even when we're talking about an infectious disease. Here, I'll give an example of the just ended, pandemic, COVID. What did you use to, first of all, protect yourself? I saw the lady, my sister was wearing a mask. You saw the mask she was wearing? We used to wear masks, isn't it? To try and prevent transmission between ourselves. Where did the mask come from? It came from the surgical space. The ventilators, pulse oximeters, the critical care personnel to intubate and keep the people who are really sick alive. Where did those come from? They came from the surgical space. Without our tools and our expertise, a lot of people would have died from COVID. Now, that's an infectious disease. But there are other hazards. There is wars going on. There is natural disasters, earthquakes. When those things occur, the first team that is sent out there is surgical, to go and make sure that those who are injured are kept alive before we even bring in water and sanitation. So surgery is very critical and important for emergency preparedness and response to all hazards. So you can see it plays a key role in every place. And so it becomes a nice tool that we can try and use. Now, to provide safe surgery or to improve surgical care, obviously we must close the gaps that we identify in the building blocks of the health system. Here you've seen the building blocks: governance, workforce, health information, infrastructure, finance, service delivery. Here you've seen we've expanded it properly at PASHEF, because again, when we talk service delivery chair, people like to think about only what we deliver in the hospital. Service delivery talks about prevention and the rehabilitation of those that are coming out of our facilities. So when we talk service delivery, or we talk about that pillar or assess it, when we're trying to develop our national surgical plans, we must assess the prevention part and the rehabilitation part. Let's not only talk about what we deliver in the facility. Now, to be able to provide safe surgery, there's a lot of other things that must be in place. And that's why we say it's a good piece to strengthen the health system. I've already shown how it can deliver good health outcomes in different areas of work in health. So we cannot provide safe surgery without good laboratory support. Isn't it? We can't operate on you if you don't know your hemogram, your urinary function, and a lot of other parameters, your heart function. Before we do operation, we have to take you to the physician to do an ECG and a lot of other things. Okay? So without laboratory support, we can't perform surgery. So good lab support is mandatory for surgery. And it's not only the surgical patient that's going to benefit from that. All the other patients in the system will benefit from it. But if we improve it for surgical purposes, other patients will still benefit from that. I've already talked about imaging. We do a lot of X-rays, CT scans, and a lot of other ultrasounds in surgical care. In orthopedics, it's mandatory. We can't do anything without looking at the bones somehow. So by improving the imaging system or imaging capacity of a facility for the sake of providing safe surgery, we are also doing it for every other patient, and the system becomes stronger. We use a lot of blood and blood products in surgery. So we need to know how to screen the blood to make sure we have good blood. The supply chain should be good, and how to maintain the cold chain and everything like that. Again, it's not only the surgical patient that relies on good blood transfusion services. Referral systems, again, sometimes we have to rush people between facilities so that they can receive the care they need in time. But if we can improve the referral system for the surgical patient, all the other patients will improve. As you know, most of the time we're even leveraging maternal health. There's a lot of investment on referral system to try and transfer mothers, because the mothers come to a facility and they can't deliver and they need a C-section, they're almost in the second stage of labor, and we have to rush them. But because of improving that service, other patients will also benefit from it. Okay? Rehabilitation and palliative care, we need it in surgical patients, but again, if that system is improved for surgical patients, it improves everybody else. And of course, information management. We generate a lot of information. Actually, this is where the biggest gap is for us. That's why a lot of things about surgical services are not known. We always write in the patient's file, we always write in our theater registry, but this information stays in the paper-based platforms in our theaters. Very little of it is actually transmitted up to the decision-making platforms. So when you ask a country about a lot of statistics about surgical care, they are blank. They don't know. It's not because the information is not there. It's because we are not managing that information properly, and that must be improved. So we're thinking of digitizing information for surgical patients. But again, like I said, we cannot do it for the surgical patient only. Because the surgical patient is a mother. The surgical patient is a child. The surgical patient can come from any other part of the health system. So by improving it for the surgical patient, we're improving it for everybody else. So you can see that to deliver safe surgery, you will need a lot of other things that you must put in place, just for one patient even. And by doing that, you are strengthening the health system to deliver better health outcomes for all other patients. Now, surgery also doesn't only impact us in the way I've explained it, it also impacts the individuals themselves. Remember, I talked about health being wealth, but also health enables people to work for themselves, to break away from dependency. It saves lives, it reduces mobility and disability. There's a lot of disability, especially in surgical conditions. Just because of a myomenited fracture, I can lose my means of earning a living if I'm a subsistent farmer. When a fracture, maybe I can even fix it. If it's something that requires open reduction and internal fixation, I can fix it in 2 hours. But somebody is poor for 5 years because nobody could provide them the care that they needed in 3 hours. So if we really are bent on trying to develop our countries, we must invest in things that help the people to become independent and productive. And surgical interventions are one very sure way that can ensure that a person becomes productive. Even their family they stop relying on their family. It has impacts on the family, on the community, and of course, on the country. Now, we as global surgeons or people working in the surgical space, we must also start looking at how we can do research in collaboration with health economists and others, because this is the language of government. Governments invest to ensure that they can have a productive population and develop the nation. And like I said, people look at health as a waste. So we put money in health and it's like it's a bottomless pit. They never really see what can come out of it. It's research like this, the socioeconomic impact of surgery, that we must be doing as well. So we can show the bang for the buck that they invest in surgical care. Now, to be able to translate these policies, like I said, first of all, you need a plan. The permanent secretary here was telling us about, give me something. Give me a strategy, give me a plan, so I ensure that it's integrated into the sector strategy and contributes to the 4th National Development Plan. That's what she was saying in the morning. That's the very sure way of having any investments. Nobody can invest in anything without knowing what you are going to get out of it or where you are taking the money. I would never give you any money of mine if you don't tell me what you want to do with it. So if we want investment in surgical healthcare, we must make a plan. We must make a strategy and show clearly what's our objective and how we're going to do it. And so policy formulation and implementation is one part. But the policies that we formulate must be aligned. Aligned with what? Aligned with the sector strategy. Because the sector strategy talks about what the government is going to prioritize for a certain period of time. So here, like she said, if this is done by this year, starting from next year up to for the next 5 years, only the things that will appear in the health sector strategy will be funded by government or their partners, because their partners also look at that strategy. So there is a saying in Zambia, or well, we like to say it in Zambia, which says, opportunities favor those who are ready. So you must get ready to get favored. So I'm saying it here again in Uganda. Opportunities favor those who are ready. Get ready to get favored by try to accelerate and complete your strategy so that there is alignment and inclusion. Okay? Now, there is also integration of the programs that we come up with. So it's integrated in the National Health Strategic Plan, but there is also another part that we have left out most of the time and we're just learning now. Every country has what we call the basic package of health services. You've heard about it, right? So WHO comes up with the essential health package, the possible things that you should be able to do to achieve universal health coverage. But every country then comes up with what they call the National Health Benefits Package. This is the package, the minimum package of services that they can afford for that time. Obviously, they can keep adding to it depending on the growth of their budget. Now, when you look at the documents, several countries have got that basic package or benefits package. When you look at those documents, you realize that surgery does not exist. It's not there. So if it's not in the basic package of services, how do you think it's going to be done, even if you have the national policy? Like I said, in Zambia, we had a policy from 2017 to 2021. We did very little. One other reason was because there were no surgical interventions appearing in the basic package of services. So while you are trying to align your strategy to the national document, also look at what's the basic. Because this package defines what you deliver at every care level. So at the clinic, we're going to do this. At the district hospital, we'll do this. That's what we can afford. So I'm challenging you, don't only focus on your national surgical plan. Try look at your benefits package and see what is there. And recommend to government what you want to be done as a minimum at the different levels of care. Unless you do that, again, it can be aligned, it can be national strategy, but in the benefit package it's not there, nothing will happen. Because even the facilities, they budget based on what is in their basic package. As a hospital, this is what we say we can do, we were recommended and we are funding for that. Okay? I've already spoken to the issue of primary health care. Chair, I hope I'm staying within time. I talk a lot. Please remind me if I'm going beyond time. Now, like I said, the whole drive towards universal health coverage mostly focuses, if for clinical services, on the district hospital. We also know that in our health systems at country level, the district hospital is the elephant. It's the facility that's not delivering what it's supposed to do. It's a facility that's closest to the population. It's also the facility where we can do the basic of what we call the bellwether procedure. The district also should be able to do a laparotomy, open laparotomy. We're thinking we can go laparoscopic, yes, but you should be able to do open laparotomy. You should be able to stabilize an open fracture. You should be able to do a safe cesarean section at the district hospital. And of course, when you look at the other UHC things, they focus mostly on the district, because we've known that in the district hospital, in the health system, patients come from the community, they may go to their clinic, but most of the time they skip both their clinic and the district hospital, and they come and congest Mulago Hospital. So everything is coming to Mulago, abscesses, closed fractures, anything. And then there's congestion, and then everybody's complaining, the workers are overwhelmed, government complains you're not doing your job, because the district hospital is not working. We want the district hospital to be able to function so that they can deliver care to the people closer to their community and earlier, because it costs a lot even for the people to travel all the way to the capital. There are non-medical costs that they are going to incur. They don't know the facility. In fact, sometimes they don't even want to come, because just coming to Kampala is overwhelming. It was overwhelming for me. So let's capacitate the district hospital so it can deliver the care that it needs. And that's our focus when we do this. This infogram, again, I'm just trying to emphasize the issue of perioperative care, which splits the pre-hospital, intra-hospital, and post-hospital. Most of us, most of the time, speak about the intra-hospital. As we try to formulate our policies for UHC, let's not forget the pre-hospital part of it and the post-hospital part of it. They are really, really important. Patients come to the facility only for a certain time. They come from their community and they go back within their community. So let's ensure those services are appropriate and are also improved. Now, this map just shows, again, the process of how we develop a policy or a plan at country level, or a national surgical obstetric anesthesia plan. Most of you have seen those stages already. I'm just showing this to emphasize two things as you develop your policy here for UHC. That the development of your policy must be inclusive of all stakeholders, especially the community. Every stage of that process should include the community. In Zambia, the first policy we developed, we left out the community. And so we didn't even know their needs. We always assume we know, but we are on the supply side of things. Maybe their problem is just the attitude that we have as health workers. We must bring them on board so we hear what are the gaps, what are the challenges they are facing with the system. Because it's a plan for all of us. And let's not forget that sooner or later, we are also on the patient side. I had to undergo a laparotomy myself some time back when I came from Geneva. I was lucky because I knew everybody. I just had to pick a phone call, blah, blah, blah. Within 3 hours, I was on the table. But we just did a study in Zambia, in Lusaka, to look at emergency laparotomy. You know the waiting time that the patients have to wait before they undergo surgery? More than 9 hours. 9 hours having reached the facility. The patient is in UTH. They wait for 9 hours before they undergo a laparotomy. Me, I was screaming and insulting by the time it was already 3 hours because I felt like people were not saving me fast enough. So let's involve the community so we understand their concerns and bring them on board as we are developing these policies. And we also must think sustainability in these plans when we make them. Let's not make plans for the Western world to fund us. It's common knowledge that the financing system of the world is changing because all of us were relying on Big Brother. The money is not there anymore. Big Brother is calling us name and we thank him for it. We must look within. We must look within. Professor Agawa was talking to you that sometimes we're talking funds only. It's not just funds. It's just not money. I remember, I'll give you a quick story. when I was president of the Resident Doctors Association in Zambia, we were always fighting with government about our conditions of service. And every time we went to the government and we paralyzed the system with strike action, we were looking for money. We want money. We want money. One time we had to change a strategy and discuss, so what do we need the money for? If they give us more money, what do we want it for? And then we realized, oh, I want land, I want a house. We wanted things that government already has. So all we did is change the strategy and went to government saying, okay, if you can't give us money, give us a piece of land in a district we want. And give us access to a mortgage at 0% so we can build the house. And you don't have to give us more money. Government was very easy to give us that money and was able to retain the doctors in the country. So it's not always about money. When we're thinking sustainability, let's look at all the resources that we have, but we must build that into the plan that we make. Now, the Pan-African Surgical Healthcare Forum is a platform that has just been created. The first one was 2 years ago. This platform was created to support the governments. It's actually a government-owned platform. The first 2 meetings were held in Rwanda, hosted by the Ministry of Health of Rwanda. Now, the platform belongs to government because Africa wanted to chart its own pathway. So create something for Africa by Africans. Because we, having worked in the global health community for a long time, we know that there's always hijacking of our ideas. We have a problem, we call everybody to the table, they come there with their own agendas. And they insert a lot of trash and hijack the whole process in the end. Even when we've talked about global surgery, the whole movement of the resolution started from here. But all global surgery meetings have been taking place in Geneva, in New York, in Rwanda, in London. There was nothing happening here. How can we be going to places like that with visa restrictions and costly exercises to talk about our problem? Why? So this platform was created that Africa can start solving its own problem using its own resources here on the continent. And the first 2 meetings were restricted because we did not want the thing to be hijacked. So it was strictly for governments, so the governments can come, agree on a lot of things, and chart the pathway. Afterwards, then everybody can come after we've already baked our cake. So this platform is there to support Africa. Again, the idea is that we must share. We must share our expertise, we must share our experiences, we must share our resources as Africa if we're going to move forward. Because none of us has got everything that they need. But when we team up together, we make a very powerful team. And we proved this at the UN, even among us diplomats. So there's always value in working together, but you always have to be strategic on how you do it. The next PASHEF meeting, obviously, is going to be open to all stakeholders, but the baby or the cake has already been baked. Now, you should leverage this platform. I know that Uganda has delegations and had delegations coming to this platform. Leverage the resources and everything and the expertise that are on this platform to help you on your pathway as you move towards universal health coverage. Now, there is also the issue of not knowing what to do. So the whole issue of developing surgical care or developing a plan, sometimes we say it's up to the policymakers to do. Here, I just want to highlight mostly the 2 arrows that are pointing there. So the policymakers have got the responsibility to build and develop a policy, and they do it from the top down. But you, the surgeons, the health workers, also have a role to play in this, because you will come with the evidence and the expertise and the experiences from the ground that informs that policy. So it's not true to feel helpless and say, there's nothing I can do. With your research, if you disseminate it properly and you do it correctly, you're going to give us information that will be very critical in the whole process. So we can develop and ensure that we can give the right interventions at the right time to get the good outcomes. This map I share with you is just a map that shows the different stages of progress in the sub-Saharan Africa. Obviously, the key is kind of very, very small, so it may be very difficult for you to see. All I can say is that African countries are at different stages of progress in terms of ENSOP formulation and implementation. Of course, we have Senegal and Ethiopia that started this process way before 2015. We have the Republic of Zambia and now Nigeria that are revising their national surgical plans. And then the other countries are obviously at different stages. I'm more conversant with Southern Africa, so I can tell you that Namibia, Zimbabwe, and Madagascar have their plans already. The rest of the other countries are at different stages. Either they are in the early stages or they start and stop and start and stop. So it's an ongoing process. And like I said, you don't have to be married to the acronym NSOP. You can call your strategy whatever it is. In the Republic of Zambia, for the sake of inclusiveness and integration, we are calling it the perioperative plan or perioperative strategy, because we want to take care of the whole continuum of care. And we don't want nurses to start saying they are not part of it, or others who are not mentioned in the acronym to not be part of it. And also we want alignment with all the other policies, including the ECHO resolution, which talks more about surgical care in emergency situations or emergency preparedness, mostly focusing on critical care and emergency care. The inaugural meeting of PASHEF recorded those countries as attendees, but the last one was up to 42 out of the 55 member states of the African continent. The next meeting will be in Rwanda, and then Ethiopia will be the next host. So, NSOP implementation is important, but you can go with an initial implementation. Once you have the policy in place, go with an initial implementation. Don't think that you can implement countrywide. It may not be possible. Choose a district, choose a province where you can do this. Now, that initial implementation is important because you want to generate the evidence, and you also want to demonstrate impact of the new policy. The impact you want to demonstrate is how it can help improve the health system. I've already tried to illustrate how this is done, or it is possible. How you can contribute to health outcomes. Here I can also give an example of maternal mortality during childbirth. The maternal mortality is not dropping. People have invested tons and tons of money, and it's still not dropping. And yet we have evidence that what kills mothers around childbirth is bleeding. You can't stop bleeding with paracetamol or a contraceptive. Yeah, you stop bleeding by surgical intervention, even if it's pre-eclampsia or eclampsia. The solution is to get the baby out, isn't it? Yeah, how do you do that? By praying? No. You have to do a C-section and get the baby out. So let's show how we can contribute to reducing maternal mortality by improving surgical care for maternal health. Even that is an impact to show. Because government and everybody is trying to do that. Like I said, let's also not only talk about health outcomes or health issues. Let's talk economics. How do we contribute to the socio-economic of the individual, of the family, of the community? Have you tracked all the patients you've operated on and seen how they perform economically after you've operated on them? You should. That's the impact that you can show that is much more impactful. Not the numbers of people you've operated. Show how you've gotten people back to work. That's more important. And of course, you're going to learn lessons from this initial implementation on how you're going to do it better, how you're going to revise the policy. Lessons are always important. Then you can then start the nationwide scale-up. How you do it, like I said, there is no prescribed way. You can just look at one facility with its catchment population. Or you can look at the district with all its satellite clinics. Or you can pick on the whole province with its districts in there. It's up to you. Now, to do the initial implementation, you don't need funding from Ministry of Health. You can get a grant, or you can put money together as a society and do that. Because once you have that evidence, impact, and lessons, it will be very difficult for anybody to argue against that, because you have real information from the ground. The key message is safe, timely surgical care or perioperative care contributes to saving lives and attaining good health and well-being, which is universal health coverage. Good health and well-being is important for economic activity in a country. Without it, nothing can move forward. And it's also an indicator for national development. So surgical care or perioperative care really can get a country to development. It's a masterpiece. Let's try and deliver this to the countries and to the people. Thank you, Chair.